Assalamu alaikum. My name is Dr. Naseem Shirzad, and today I'm going to discuss with you all small renal masses and partial nephrectomy and their step. We will be discussing in detail the step of the partial nephrectomy, the indication, the contraindication, and complication of the partial nephrectomy in detail. So, before going to discuss all these, let a quick review that clear cell carcinoma 80% is 80% and that rising from proximal convoluted tubule, and then papillary RCC, which is the next common, and that is 10 to 15. It's also rise from proximal convoluted tubule, and it is a childhood RCC. The remaining chromophobes and collecting duct RCC, and that multicystic, mucinous, and undifferentiated, that are very rare tumor. But medullary carcinoma is important as it is occur and related in a patient with sickle cell disease. Right. So now, how will you differentiate RCC from TCC on CT scan? RCC is actually brightly enhancing on CT. RCC is located more peripheral, while that TCC is located centrally. Uh, RCC distorts the pelvic urethral system but does not infiltrate it. RCC never fill up the pelvic urethral system, while TCC fill up the pelvic urethral system. RCC having central calcification on CT, while TCC having peripheral calcification. On clinical presentation, RCC may present as abdominal lump versus hematuria by TCC. As RCC having very late presentation of hematuria, right? And now let's discuss the some important point that in how much percentage of lymph node involvement can be seen in each stage. That's also important. And see for the tumor size that 0 to 2 centimeter mass much of the time are benign. So this is a little bit detail of the tumor. Now coming to the definition that the of partial nephrectomy, complete local resection of the diseased renal parenchyma, leaving the largest possible amount of renal function parenchyma in the involved kidney. And you should to left at least 20% of the parenchyma behind to prevent a patient from end stage renal disease by having solitary function kidney or normal kidney. So resect and should leave at least 20% of one kidney. So it's important. Now coming to the intraoperative renal ischemia concept, and the intraoperative renal ischemia concept is this is temporary occlusion of the renal artery is necessary in nurse sparing surgery. And temporary arterial occlusion not only demands intraoperative renal bleeding. One, the purpose of this occlusion is to prevent the bleeding during surgery, but it also improve access to the intrarenal structure by causing the kidney to contract and by reducing the renal tissue turgor. So that's why there are two purposes. Number first is to decrease the blood supply and to have a clear surgical background and less bleeding. And the renal artery occlusion causing reduction in medullary blood flow with reduction in oxygen delivery to the tubular structure, and this will lead to cellular injury due to imbalance between oxygen delivery and demand. Endothelial injury lead to leukocyte activation like cytokines, etc. So renal tolerance to warm ischemia is that the extent of renal damage after normothermic arterial occlusion depend on the duration of the ischemic insult, and the warm ischemic time for kidney is 30 minutes. If it is beyond 30 minutes, so there will be problem in the recovery of the renal function, and it will be either incomplete or absent. And we know that this ischemia affecting the proximal convoluted tubular cell, while the glomeruli and blood cells are generally spared. And it is also important as compared with the paired kidney, the solitary kidney is more resistant to ischemic damage than the paired kidney. So this is also important. So this is all about the concept of renal tolerance to ischemia and It should not be exceed more than 30 minutes. And the method to apply this vascular ischemia, this can be done by various methods, but actually we are performing the cold ischemia, that we applying the bulldog and then we give the cold ischemia in form of ice slush, and for which we are using many kind of methods. So the general principle for the prevention of ischemic renal damage is that the preoperative and intraoperative hydration, prevention of the hypotension, avoidance of unnecessary manipulation or traction on the renal artery, intraoperative administration of mannitol, these factors ensure perfusion with an absence of cortical vasospasm at the time of arterial occlusion, which allow uniform restoration of blood flow throughout the kidney when the renal artery is clamped. So these maneuvers should be applied. Now, how to give mannitol? Mannitol is most effective when it is given 5 to 15 minutes before the arterial occlusion. So it's important to give 20% on 1 milligram per kg if a patient weight is 60 kg. So give 60 milligram of mannitol, and it should be given before applying the bulldog, means 5 to 15 minutes before applying the bulldog, right? And what's its importance? Its importance that increase the renal plasma flow, decrease the intrarenal vascular resistance, and leading to minimizing the intracellular edema, and this promote the osmotic diuresis when renal function is restored. So it having actually a protective measure. Other protective measure is local hypothermia is most effective and commonly applied method as we are doing. So the lowering renal temperature, reducing the energy dependent metabolic. Why we are giving this cold ischemia? Because it reduce the energy dependent metabolic activity of the cortical cell, with resultant decrease in both the consumption of oxygen and the breakdown of adenosine triphosphate. And this optimum temperature for hypothermic in situ renal preservation is 15 centigrade. But you know, when we are putting that 15 centigrade, that can be shifting to the adjacent structure. So that's why we are giving around 20 to 25 centigrade to achieve at least 25 15. So it is difficult to achieve uniform cooling to this level because of the temperature of adjacent tissue and need to expose a portion of the kidney to perform the operation. This temperature of 20 to 25 centigrade is easier to maintain with renal preservative effect, and the level of hypothermia provide complete renal protection from renal arterial occlusion for up to 3 hours. So now if we performing this surgery without this hypothermic effect, we can do only it for 30 minutes, which is called the cold ischemia. So only applying the bulldog to the renal artery without hypothermia, that is called warm ischemia. But if you apply the hypothermic effect along with the application of the bulldog to the renal artery, that's you can prevent the renal injury for up to 30 hours, but much of the time you can perform it the preferred is 90 minutes, right? So this is important and concept regarding. So now the next, how to perform and achieve this. There are multiple methods that can be done to achieve the hypothermia in situ renal hypothermia. One concept is that of the in situ renal hypothermia, like external surface cooling, that we putting ice slush on the kidney. The other technique is the perfusion of the kidney with a cool solution into the renal artery. We putting a syringe into the renal artery and we starting a continuous perfusion. The third concept is that we already have placed a retrograde catheter, and we will be using a cooled saline, cooled water through that retrograde catheter. Now, in which condition? For example, this is you are performing laparoscopic surgery in which you will be unable to place a ice slush on the kidney. So, in that condition, you can go either for putting it directly to the renal artery or through retrograde catheter. So, these method imported in case of laparoscopic or robotic surgery. This is the various ice slush mechanism, that is a sterile that is put around the kidney. After applying the bulldog, then put a slush around the kidney. Why we are not using this cooled solution via renal artery? The reason behind that, it can cause systemic hypothermia. It can increase the risk of tumor dissemination, and it can lead to repairing of the artery. That's why we are avoiding much of the time this. Now coming to the detail that should be observed before going to perform a surgery, we should have an appropriate score, which is also called renal score. There are other score which can also be used, that is called pedo score. So the what is the importance of this renal and appropriate score? This is actually used to categorize renal mass into low, intermediate, and high complexity based on their cross-sectional imaging finding. Its purpose is to aid in decision making, patient counseling, surgical planning, and patient follow-up, as well as for academic reporting. So, nephrometry score is important. Second, it's also important before going to operate a patient to have a clear-cut understanding of the vascular anatomy, like there may be present multiple renal artery. The third is the amount of perinephric fat and presence or absence of perinephric stranding that can make our surgery difficult. Presence or absence of other renal mass is also important. Proximity of the ureter to the renal mass, especially for lower pole mass, that's also important. And renal anomalies like the kidney may be pelvic or horseshoe kidney. So before starting or embarking on surgery, you must have these things in your knowledge. This is a nephrometry score, and we have also discussed that in a detail, that how to perform. Now coming, what are the indication for partial nephrectomy? The indication, any T1 means 0 to 7 centimeter, even with normal functioning contralateral kidney, a tumor in solitary kidney, bilateral kidney tumor, if a contralateral kidney is threatened or affected by stone, CKD, hypertension, Wilms tumor. And what are the contraindications? Nodal Mets positive, IVC thrombus, renal vein thrombus, pelvic system involvement, renal hilar involvement. So these are important contraindication. Now the scenario coming, if you have bilateral renal masses, how to operate that patient? So we have two options. If the masses are small, we can go for bilateral partial nephrectomy. If the masses are large, then we will operate partial nephrectomy on one, and then the partial nephrectomy of the other one after 1 month. Now coming, the what are the steps of partial nephrectomy? It is performed under general anesthesia. We are putting actually retrograde catheter and catheterizing the patient, and then we position the patient on lateral flank position, and our approach is extrapleural, extraperitoneal, and our incision is supra 12 or supra 11, and that should be identified on the X-ray cavity which you have. And now coming to the procedure, we are opening, actually entering into the retroperitoneal space. Then we are looping the ureter and applying the self-retaining retractor. Then we go toward the hilum and dissecting the hilum. Then we loop the artery and vein and try to as much as possible to not manipulate a lot the artery and vein. After taking the artery and vein and loop start mannitol, we have discussed that what's its purpose, and 20% in 100 ml means 60 milligram of it having weight of 60 kgs, we are giving it 1 milligram per kg. So the positioning, the anesthesia, all these important. So after taking the renal artery and venal loop, start mannitol. And after that, remove the perinephric fat around the normal part of the kidney. Don't remove the perinephric fat over the tumor, because that may be a malignant fat. So that's why don't remove from the mass over the kidney. Then next step is clamp the artery with bulldog clamp, right? And then cut a hole of a plastic sheet and place kidney into it around it. And then after applying the bulldog, put ice slush around the kidney for around 15 minutes. During this time, it's important for this 15 minutes to arrange your things, like better to have your 4020 vehicle in these 15 minutes and all your things to be in place. So the time after completion of 15 minutes, displace the ice, mark the tumor and excise with cautery. Visible open blood vessels are sutured with bigger of 8. Send the frozen section, some institute sending, some not sending, and then push 10 ml methylene glue through already placed retrograde catheter at a ratio of 1:1. If there is any calyceal system opening is seen, close it, and if you want to put the catheter, pass the guide wire to this calyceal opening and put the DJ through that hole and close it. Then the frozen section, if negative, close the kidney over and after hemostasis achieved, kidney aspects to posterior musculature to avoid flapping. And so these were all the step of partial nephrectomy, and these are the various technique to be applied like enucleation, polar segmental nephrectomy, wedge resection, transverse resection, and extracorporeal partial nephrectomy with the autotransplantation. I will not go in the detail of this. Now, what are the complications? These are the intra, post-op, and late-op complication. And post-op bleeding is common, so better to have understanding how to deal the bleeding post-op. And this is the follow-up protocol for the patient of partial or radical nephrectomy. And now let a better discuss the thermal ablative therapy. These are the alternative like cryosurgery and radiofrequency ablation. Cryosurgery is done for a mass more than for mass less than 4 centimeter, and radiofrequency ablation is done for mass less than 3 centimeter. And the indication for thermal ablative procedure are patient with local recurrence after partial nephrectomy, patient having hereditary RCC, advanced stage, patient not fit for surgery, and the size is less than 4 centimeter. But the most important among these, to have a biopsy report in your hand before performing these thermal ablative therapy. Right, so these are the option for SRM, small renal masses. Right, so for small renal masses we have three options like thermal ablation, active surveillance, partial nephrectomy. Thermal ablation we have discussed. Active surveillance is done for small masses, well marginated, homogeneous, non-cancer cause of death and the risk of intervention, but again must have biopsy in your hand before going for all these options. So this was all the detail of